there is ligamentum flavum hypertrophy at L4-5 level with bilateral lateral recess.
Can you zoom in more?
Zoom kar denge. So there is an element of lateral recess, again left more than right.
Right.
Okay, and on SAG, here there is quite a thick ligamentum. With inferiorly there is compression. Okay, and as far as foraminal stenosis is concerned, just one cut before the where you have the foraminal cut, you have significant stenosis that is seen. So Ramesh is going to do the procedure, and the plan is to do not just a interlaminar epidural but also a left far lateral transforaminal. Are you there with us?
Yeah, just say that again.
So the plan is that we'll do a interlaminar epidural along with a left foraminal root block.
Left foraminal root block.
Yeah. So if you look here, ye yahan dikhayenge, there is again an extraforaminal component.
Yes, we can
which
see
is quite significant.
Yes.
On the left. So that is why we are taking a far lateral approach for the transforaminal block, and we'll give a epidural shot as well.
Phylum, can you show Asheesh? Dr. Mahapatra wants you to.
Phylum I can show. Here you can see the phylum tail. Not very clearly seen here, but here this, then this cut, then in here.
Right.
This is the phylum going in. Here.
Conus, can you show?
Yeah, why not? Conus is ending somewhere around this.
Yes.
D12, L1 pe
Correct.
it is ending here.
Correct. Yes, sir.
Yeah.
So, Dr. Asheesh,
Yeah.
so you said this patient had, because he's got a lateral recess stenosis
More
on the left side,
More on the left, yeah.
you plan to do a transforaminal root block,
Yeah.
which will be a pure just for that, specifically for that root.
For that specific route.
So it will be a little extra foraminal you're trying
We'll
to
do exactly, I mean, Ramesh would be doing exactly the same thing that we did for the first case.
And, okay.
And then, ideally, even if we do a interlaminar epidural in this case and observe, that should be more than enough. But we are in the interest, we are doing not just a interlaminar epidural, but also a far lateral.
Okay.
Okay. So we are marking.
Right.
Marker pen, please.
So normally, Asheesh,
Yeah.
for these patients, when you are doing in your OT, in your OR setup there in Jabalpur, what is the monitoring you set up, and what is the what are the number of people you require for this?
Number of people, huh?
People means technician.
Okay,
nurses.
so we'll require one anesthesia nurse.
Right.
We'll require a CM technician
Right.
and one scrub nurse. That's about it.
And monitoring, what monitoring
So
is?
we do, so the standard monitoring, we'll have a pulse, BP, ECG,
Right.
monitoring going on.
Sir, this is a lumbar canal stenosis, the central canal stenosis with bilateral root compression.
Yeah.
So how effective is an epidural or any kind of drug going to be in this case? Because here the compromise is on the blood supply to the nerve root because of compression. So how effective is the medicines what you're going to put in going to work?
Yeah. So basically, we have a level 4 evidence as far as targeted epidural is concerned for lateral recess. So the difference to the extent is that for radicular pain secondary to disc, we have level 1 evidence, which is the best evidence you can have. Whereas for a lateral recess, you have just a level 4 evidence.
All right.
So, you know, some retrospective studies demonstrating and truly not a great consensus.
Okay, sir.
Yeah, this
So
is
in
good.
this, we are first trying to get that flat parallax.
Yeah, we have removed the, so the end plates are absolutely parallel. थोड़ा सा ऊपर ले जाइए और. And you know, in this patient, if, नहीं, sorry, ऐसे ही, बस सिर की तरफ ले जाइए. And can you show it here? आप यहाँ दिखा सकते हैं. So if you see here, there is sort of a, ऊपर ले जाइए. There's a reversal of the C-arm position to get a the parallax. So generally the receiver is tilted towards the head, but in this patient we have to tilt it opposite. So what I'm trying to emphasize is you need to square each level rather than having preconceived
Correct.
fixed angles.
Correct.
हाँ दिखाइए, थोड़ा नीचे ले जाइए. नहीं, ये इसको ऐसे ही रहने दीजिए, बस ये नीचे ले जाओ. हाँ, शूट प्लीज. मिड लाइन, नीचे, कम डाउन. शूट प्लीज. दिस इज द राइट पॉइंट. सो वन इज हियर. नाउ लैटरल ले लीजिए. हाँ, बिकॉज इंटरलैमाइनर में मतलब जनरली लैमाइनर स्पेस नीचे रहता है. ओके, लैटरल प्लीज एंड रिमूव दिस टिल्ट. चलो, हु स्क्रबिंग? तू स्क्रब करना प्लीज, फटाफट करते हैं. यू स्क्रब ना? ओके. सो लेट्स शो द लैटरल. सो नहीं, लैटरल इधर. हाँ, इधर. हाँ. So now you want to see, now we'll mark the facetal hump. Shoot please, of L4-5 level. Are you there with us, Deepak?
Yes,
Okay,
we are looking.
okay.
We are looking at it.
So what do you want to do, Ramesh? C-arm नीचे ले जाइए.
We need to go a little more inferiorly, I think.
Exactly, बढ़िया. और नीचे ले जाइए C-arm. Okay, shoot please.
Go superior.
Shoot.
Yes.
Reasonably good, but you can go still lower down. Yeah, shoot. Yeah, this is the perfect place. So let's mark this. छोड़ दो. Okay, local please. आप scrub कर लो. मुझे दे दो. I'll paint. ये साफ कर रहे हैं प्लीज. So till Ramesh is scrubbing, if there are any doubts, questions, I'll be more than happy to answer.
I think we have learnt a lot.
All doubts cleared, huh?
No, I think doubts will always remain, but getting cleared.
Scrub. Drape please. हाँ, लोकल दे दो. मैं अभी डाल देता हूँ. बहुत कम है सिस्टर.
That will not work. You just I will ask him. Let him answer. Asheesh.
हाँ, yes.
There's a question from the audience that when should we consider the epidural block and when should we consider transforaminal block?
Okay, so results of transforaminal blocks are better, especially for, see, idea is you need to spread the drug to the area of pathology. If your patient has exclusively a one-sided symptom, obviously you don't want to go on to the opposite side. But if you have, like for instance, central canal stenosis, where you want to put in,
Right.
or when you have bilateral recess and you just want to use one technique, then, or more importantly, when it is a post-operative case, then you can go, because there will be obviously fibrosis, so you can go interlaminar.
Post-operatively, I think we are all clear. There's going to be fibrosis and adenolysis can only
Injection
be
लगा
happened with epidural technique.
बस एक इधर बस बस सॉरी, और एक इधर लगेगा आपको, थोड़ा बीटाडीन मिलेगा, बस बस बस.
Sir, the transforaminal needle you have, is it commercially available or?
It is very easily available now. Previously there was a problem. So हम लोग क्या करते थे? We used to ask the urologist who used to do the nephrostomy and PCNL. They used to use that type of a needle. But now it is being marketed as a transforaminal needle. बहुत आराम से मिल जाता है. The long needle. थोड़ा बीटाडीन, बहुत इजीली. हाँ, थैंक्स. साफ कर रहे हैं. चलो दोनों देखते हुए ड्रेप कर दो.
A high dose of systemic steroid, can it achieve the same result of this, sir?
Yeah, come. Are they asking? Yeah, Deepak, anything? Any question?
No, no.
Okay, okay.
Yeah, around questions, sir.
One question from the audience. Yes.
Sir, the high dose of systemic steroid, can it achieve the same this local steroid effect?
Sorry?
Systemic steroid, IV steroid.
Yeah, any difference between systemic steroid versus?
This local steroid.
Local.
No, I mean, what do you want to know?
The same result, can it be achieved by high dose of IV steroid? Instead of this transforaminal local steroid,
Yeah.
and the same result can be achieved by high dose of systemic steroid.
Yeah, yeah. I mean, see, in the past, previously, we have been using steroids, systemic steroids, and even now, for cervical radiculopathy, we do tend to use steroids for the short term. However, it is definitely more effective than the systemic steroid. That is number one. And number two, the side effect profile. Now, adrenal suppression, for example, is extremely low, though it has been reported, even with local, but adrenal suppression is very low with a local steroid injection, whereas it is quite high when you give it systemically. Similarly, osteoporosis and other complications of steroids.
Having said that, I think systemic steroids have a role in acute pain. We give our patients all of a dexamethasone or whatever for a short period, like 1 week, 2 weeks, and they have
Whatever
a
you
very
want
good
to do.
response. So I think drugs will always remain the first choice, which could be painkillers like pregabalin or steroids. If they don't work, these are all chronic patients over years, you know,
AP कर दीजिए
who have not benefiting, and some of them
20.
steroids also stop helping after a few days, weeks.
हाँ, बहुत आराम.
Targeted to that nerve, I think, is the key, and what they are
अरे,
what we are trying to show in all this.
बहुत सस्ता. अच्छा, वो मैं बताऊंगा तुम्हें. I'll. तो let's do a AP. So वो angle वैसा ही कर दीजिए. So you do it simultaneously. You put both the needles so that the radiology shots are less. Yeah. So what we have planning is हम first we'll do the transforaminal.
Right.
And Ramesh is starting the case. Okay. Yeah, the bevel is directed upwards.
Okay, Ramesh, we are all watching you, so that you don't get pressurized.
No. Go like this, straight. No, straight. Just go straight. Yeah, and now go, because this, you know, the level is almost here. Now go inside. No. Go. Take 5. At least go 5 centimeters inside. Otherwise, X-ray will not. बस. अभी नहीं आएगा. और जाओ अंदर. हाँ, shoot please. और जाइए. Yeah, on the left. Shoot please. Okay, जाइए. Now, if you see the audience there, this is typically a high iliac crest. So
Right.
the iliac crest is not just crossing L5 S1, but it is way beyond L4 5 as well. हाँ हाँ जाइए जाइए शूट कीजिए हाँ गुड you'll feel some resistance when you're entering the foramen or you'll feel bone. Shoot please. नहीं you've gone too much. और थोड़ा सा ये पैरालेक्स भी इसको और इसको थोड़ा सा सीधा करिए थोड़ा सीधा करिए हाँ बस 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 शूट करिए yeah this is better okay you have to go superior huh? Go little superior no come out otherwise you won't be able to place it huh? Go go yeah just wait here now let's not take up the other procedure let's do a lateral first yeah we are in the foramen yeah AP
Ashish, and this the tip looks to be superior. The bevel is that just the view we are looking?
no you are correct इसको rotate कर लीजिए rotate कर लीजिए yeah so it is not superior it was rather directed towards the right side
Okay. Okay.
so caudally yeah shoot करिए देखें कहाँ है so you are outside okay so now I'll tell you a trick you hold where it is entering so under no circumstances will you take on the lateral profile you will not allow the needle to go more than this because otherwise you will penetrate the dura on AP you understood when you are going inside the foramen you hold the needle at the skin level so once you are pushing it on a lateral you cannot go beyond this ठीक है चलिए pull it out about 2 inches further yeah and now take the bevel down lift the needle up lift it up now go in go no bevel pointing up yeah now go हाँ shoot करिए एक बार दिखाइए your hand is coming you'll have to remove your hand ये भी हाँ okay shoot हाँ still again pull out bring your hand here don't take it there go up further up now go that is iliac crest so yeah shoot but you won't be able to see the crest here so you'll have to do a AP for that but anyway एक AP shot लीजिए yeah but good no yeah so we are again doing AP tilt वैसे ही कर दीजिए हाँ now shoot now take it in AP but it has to go down because you are absolutely parallel so the needle has to go down हाँ चलो कर are you hitting the bone हाँ so that means yeah no you'll have to come out inject the local इधर and then go like that same yeah come out yeah come completely come out go above yeah local and I'll also come can I get sterilium please thanks bro sister I need a gown और दे दीजिएगा please Yeah, okay. Go in. हाँ जाओ ना. चल. Thanks, sister. Sorry. Sorry. Yeah. सियाम बाहर लीजिए. हाँ हाँ. Perfect. Perfect. Keep going. But no, take your hand like this. Now go. Yeah, go. Keep going. Down, down, down. हाँ, चलो. Shoot, please. Yes, good. Go down. Shoot, please. Excellent. Go down. Go inside. Shoot. Perfect. Now let's do AP. So here, friends, we are the iliac crest was obstructing. We have just entered a little higher up.
Right. So you made a new entry point?
Yeah, yeah, we made a new entry point.
Okay.
Okay, shoot please. इसको सेव कर लीजिएगा. Oh, beautiful. So this is a very good location because it is towards the anterior side.
Right.
Okay.
Right.
So this is a good location. Now we have of the theca in the anterior portion of the neural foramen towards the disc. Okay, that is a very good location. Now AP कर देंगे फिर से. चलो, you put the dye now. You understood? No? Iliac crest, we went above and directed downwards. So the AP mein, it is always the lower part, lower end plate of the upper vertebra. Yeah, we करेंगे ना shoot. Shoot please. Die please, sister. Yeah. I think with the stillet you can push a little more inside. थोड़ा और. Yeah, so on AP, it is always this inferior end plate where you target. So you will never sort of touch the nerve, neither the exiting nor the traversing route. Because this is the 𝐂𝐴𝐵𝐵𝐻 triangle. You are in the 𝐂𝐵𝐵𝐻 triangle. So it is the safe zone. You can still go inferior to it. Not an issue. Okay, just a little bit. Shoot, please. Yeah, great.
So are we touching the bone now?
No, 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 no. See, bone is away.
Right, understood.
Yeah,
Understood.
because we are in the foramen.
You are inside the foramen.
Foramen,
Okay.
yeah. So, die please. Yeah, dull. Just put 0.2, 0.3 cc to begin with. Very limited. So that if we are not in the right place, we don't sort of blur the, so image will become black. Yeah, shoot karo. Shoot please. नहीं अभी गया नहीं है. डाई पहुंची नहीं है. डालो. Yeah, this is the exiting route. ठीक है, your exiting route. You can still go a little more inside. You will
Okay.
shoot please. Yeah, अभी तुम और थोड़ा अंदर जा सकते हो. Shoot करिए. Yeah, now shoot please. So now you can see the root
Yes.
and inferiorly there is no spread. There is very poor spread. Chalo, drug please.
Can we have a lateral view also?
Yeah, yeah, why not? Lateral ले ली. एक मिनट पहले, हाँ चलो lateral दिखा दो. Okay. 2 point. So this is 0.25, right? सेंसॉरकेन है ना सिस्टर, 0.25 है ना?
सर दोनों OT में केसेस
Yeah, but the concentration you had taken was 0.25, right?
इसमें
हाँ, okay.
राजेश मीना कर रहा है OT1 में, OT2 में.
Okay, shoot. Okay, so you can see the root, na? Can you see the root here? Deepak?
Yes, yes, we
So the root is going ऐसे anteriorly जा रहा है, and you are bang inside the foramen, which you have confirmed on AP and lateral.
Yes, beautifully seen. So now you're going to do the same solumet, this thing.
Dexa. I use Dexa. Shoot,
हाँ.
please. Okay, ठीक है. AP कर लो तो AP में और दिख जाएगा. Yeah. So we'll put just half of it. Tilt कर लीजिए. Yeah, shoot now. Okay. ठीक है, Deepak?
Yes, yes.
Okay.
Very nice.
Okay. So now we'll finish this one, and he'll be doing a small interlaminer as well. Still it, please. The midline interlaminer, sorry.
क्यों दिखा रहे हैं? राजेश मीना कर रहा है ना?
हाँ, AP में वो देख लो, आपने लोकल लगाया हुआ है.
वो तो क्या कर रहा है?
So no, the best thing
उसमें
is
पर वो लगा
you
दो
do it like this, so that radiation-wise your hand is safe. जितना. Shoot, please.
हाँ तो 2 मिनट लगते हैं उसको करने में. क्यों? हाँ तो दुर्जय को बोलो करे.
Okay, बस. Now you
हाँ,
will
हाँ,
need a
हाँ, हाँ,
feel.
तो फटाफट
डालो अंदर.
खाली करना है.
हाँ,
सब लोग बैठ
हाँ,
रहे हैं.
डालो.
पहले करने से. हाँ हाँ बिल्कुल. अर्जेंटली बंद करो उसको.
डालो.
हाँ हाँ कल करेंगे.
और डालो. देखो. बोन आया. नहीं ना? हाँ. ऐसा रफ सा वो आएगा. एक मिनट बताता हूँ, फिर मैं बाहर निकाल लूँगा. ले लो. हाँ, अभी करो. नहीं ना? हाँ, अब डालिए. So now we are doing interlaminer. He is trying to figure out loss of resistance.
Right.
Okay. Now also wait, Ramesh. Unlike in cervical here, lateral कर दीजिए. You should do this under lateral, because you are very sure that you will not damage the theca. So
Right.
instead of AP, you can very well go laterally. Yes. हाँ, ठीक. कर लो नीचे थोड़ा. हाँ, okay. Good. What I'll suggest is just go a little like this. एक shot लेना please. Yeah, this is better. Go. मतलब थोड़ा higher up. Now go inside. You should get that feel. It's called a typical gritty feel. आया? हाँ, good. And then sudden give way you will have. Sudden give way. So he is checking loss of resistance, and there is quite a bit of resistance, so he hasn't penetrated.
Okay.
बोन आ गया, तो ऊपर ले लें अपन थोड़ा सा. हाँ, थोड़ा सा. ठीक है? हाँ, तो शॉट ले लीजिए. Yeah, but the interlaminer space is always a little lower to the disc space. So the other thing, other possibility is you are hitting the opposite side lamina. You might have gone a little on the left, on the right. Yeah. So you have to remain straight. Short, please. You're there itself. हाँ अभी नहीं बस शूट लीजिए. हाँ. Yes, not the spinous. Spinous process is called. हाँ वो हो सकता है. हाँ बस sorry.
That is the wincing you were talking about?
No. I just tried to pull out because we were not at the right level. हाँ एक मिनट शूट करनी है. हम कहाँ पर हैं देखें. So we are right there. अब एक बार AP कर लो. हम we may be on either side, touching the lamina. AP में फिर से एंगल कर लीजिएगा थोड़ा सा. स्टिलेट देंगे प्लीज.
Asheesh, when we do lumbar puncture or epidural, we do it in the lateral position. You know
Yeah.
that
Yeah,
fetal,
yeah, yeah.
fetal position. Can we do it in that also?
You can do, but you know, 𝐶𝐻 pictures, they don't come very well. And understanding the 𝐶𝐻 anatomy on lateral, I mean, we do it, but see, are you seeing this picture?
Yes.
We have gone more towards the right side.
Right.
That is why we are hitting the bone.
Right.
Okay, so go straight. So angle like this and go straight. Yeah, you should be able to, but go slowly. नहीं और नीचे करो. हाँ अभी करो. हाथ हटा लो. हाँ okay, shoot please. Okay. Go.
Ashish, there's a question that for positioning of these patients, is there a difference between epidural and normal transforaminal in terms of?
Yes. In epidural, you generally tend to push a sort of a pillow under the abdomen, whereas in transforaminal, you really don't require, because already the space is 2.5 centimeter wide.
Okay.
So there's so much of space. Here, because of the interlaminar, if the window opens a bit with some amount of flexion, as we do for a discectomy, it's good.
So you just put it on bolsters, the patient?
No, not bolsters. We just tend to, because the patient is conscious, at times bolsters can become a little uncomfortable. And you are not very worried about the venous congestion. So you just push in a pillow under the abdomen.
Under
lower
the abdomen.
Lower part, yeah.
Okay.
आया? नहीं आ रहा? You got it?
Image
Good.
frame.
Push it further.
Wilson frame, I don't think so. Patient is conscious. Will not allow.
No, Wilson frame, until unless it is a radiolucent frame. Otherwise, because you need AP lateral, तो problem हो सकता है.
And conscious patient.
हाँ, yes.
Another question is image guidance, neuronavigation, any role?
You have answered it yourself. Shoot, please. हाँ, तो अब lateral कर लो.
Yes.
other side, yeah. So best is to use the stillet. ठीक है? And चलो मैं देखता हूँ. करो. हाँ, ठीक है. छोड़ना. अब अभी कुछ मत करना. हाँ? Inside, okay. Loss of resistance. But it is too up. We don't really want that up. दिखा. This is a good place. हाँ. दिखा.
So you're inside epidural?
Just about. Not yet. And उस समय भी I don't think so we were inside. बस बस बस. Push sponge please or gauze piece please. Thank you. बस कुछ नहीं कर रहे हैं बेटा. ज़्यादा ऊपर आ रहा है पर रमेश बोन है उधर.
I think after this case we should not drill anymore.
उसका क्या महिंद्रा वाला का
2
क्या?
बज गया वो अभी तो सर अभी केस ले जाओ ना.
हाँ.
तो ये तो सोचिए पोस्टपोन करो.
बोन हियर दिखा.
होना
नहीं, दिस इज टू हाई.
कल
एपी कर लो.
खा लिया सर ने. नहीं वो तो है ही है. खा लिया. आधे खा लिया.
एपी शॉट ले लो और एंगल ले लो.
तो अभी
चलो दिखाना प्लीज ताकि हम सही जाएं. दिखाइए प्लीज. ओके गुड. दिखाइए. दिखाइए. ओके lateral. Lateral. Very limited space है इधर. Can't be sure. Let's see. Check करते हैं. Shoot please. कम height कम करो आप अपना. Yeah.
Ashish, what do you think? Where we are?
Yeah. I'll just discuss. We have sort of repositioned. We have got it into the center. Still, yeah, now I got it. Shoot please. Yeah, now I've got it. Sister, die दे देंगे. So bang in the midline. Yeah, we were touching it on one side. Shoot please. Yeah, okay, ठीक है. Okay, shoot please. Drug. So Deepak, now we are in the epidural space.
Yes, very nice.
Yeah. एक AP shot भी लेंगे. Just want to, you know, it is always good to see the spread. So on both AP and lateral. Yeah, दे दीजिए. नहीं, we want more. Tilt करके लीजिएगा shot. बस. Yes. You are hitting it. Yeah. थोड़ा सा डाय देना. Shoot. Yeah. Now you can see exiting epidural as well as traversing. Deepak, can you appreciate?
Yes, can you point them out?
Yeah, why not?
We can see the
No, just put
exiting
the
on
drug.
the left side.
Yeah. So this is the.
Your head is coming, Ashish.
Oh, sorry.
Huh.
So this would be the exiting route here.
Right.
So the route must be just above to this die.
Correct.
And then this would be the traversing for this level.
Okay.
And this is the central epidural steroid. There is some amount of spill on this ipsilateral side as well, if you see
Yes.
this strand.
Yes.
And then the epidural is flowing down. Okay?
Nice. Very nicely.
Yeah. Put the drug. Yeah. Around, how much is that? And how many ml? So put 1, and then we put steroid, and then another 0.5 ml. 4 mg.
Thank you, Ashish.
Thanks, Deepak.
Any questions?